Nice to meet everybody. My name is Bradley Eichard. I am medical director for the lung screening program at First Health, and a pulmonologist with Pinehurst Medical Clinic. And glad to be here this evening. Also have the privilege of serving on the board for the Lung Cancer Initiative and all of the great work that the organization does across now two states, North and South Carolina. So we're super excited about that. Lung cancer screening. I'm glad to be able to pitch hit a little bit this evening for Dr. Mehta from UNC Rex, but I wanted to touch base a little bit on our lung cancer screening and where we got and came from. But honestly, most people don't know this, but before 1980, the ACS actually did recommend annual lung cancer or annual cancer screening with chest X-rays and even sputum evaluation, where we would look at this under a microscope. Ultimately, we deemed that it really didn't show a difference in mortality over time, and so we knew that we had to do something better. And what do we do in that process? But really, kind of the first pivotal study that looking into this was the LCAP study from the Early Lung Cancer Action Project in New York in 1999. But it showed a five-fold difference in early detection of lung cancer in patients when you compared chest X-ray to CT. And so from 1999 on, we started to look further into the National Lung Cancer Screening Trial that looked at patients between 55 to 74, the Nelson trial in the Netherlands, the MILD trial in Italy. And as we moved forward throughout this is actually where our first series of recommendations came for the patients between age 55 and 74, a 30 pack year history, et cetera, that showed a near 25% and or so reduction in mortality associated with lung cancer. And over the years from 2013 through now 2023, from the American Cancer Society adopting our changes. And then in 2021, the U.S. Preventative Services Task Force changed recommendations to include age 50 years old, a 20 pack year history, have quit within the past 15 years. And so these are folks that help us look at a higher risk population to find early lung cancers in this setting. But when you look back, the Early Lung Cancer Action Project started in 1992 after the recommendations for screening changed from the American Cancer Society in 1980. Data from that came out in 1999. And then as we moved forward with each of those trials, we started to see a difference as we move forward. The most common question that I receive when I present somewhere, or if I'm out talking in the community, or even with patients, is what about our non-smoking population? And we see this a lot, but there's a lot of things that are associated with the development of lung cancer who are non-smokers. And of course, what we see a lot, especially in February, is our Radon Action Month in the month of February. But radon is a gas that comes from the ground that does increase the risk for the development of lung cancer. It is the second leading cause. But then we also look into secondhand smoke exposure, biomass fuels, the firemen that are exposed to the burning of chlorinated or fluorinated hydrocarbons, special ops in the military that are associated with increased risk for the development of malignancy. Here, where our practice, we have a really significant number of military personnel that are exposed to these things as well. I was kind of floored as I started to dig around by this, but I didn't know that the second leading cause of death in lung transplant patients is actually lung cancer. And so these are other populations of patients that also, are kind of people that we care for in this community. I think it's important too to know that we are trying to figure out some of these exposures and what does this look like in the future. I think this is pretty interesting to me. The rates of adenocarcinoma in patients. This was a study that looked at between 1993 and 2015 of the increasing rates of adenocarcinoma in both men and women in Taiwan associated with air pollution. And so these are things that we've got to think about, especially with patients who live in bigger cities that may be exposed to this. This is one of the things that we're starting to see over around the world with changes in lung cancer screening guidelines. The Chinese Health Ministry changed some of their recommendations for screening to include patients not only just between the age of 50 and 80 and have a smoking history, but they also started to include secondhand smoke exposure, occupational exposures, as well as family history and incidences of locations. So there's certain provinces in China that have a higher development for the development of malignancy. We're working on this. Some of the data from the World Congress of Lung Cancer was released in 2023 for the FANS study, which is the New York Female Asian Non-Smoker Screening Study. And it's recruiting Asian females between the age of 40 and 74 that have smoked less than 100 cigarettes in their lifetime. The prelim data on this is rather shocking because nearly 1 out of 100 Asian females were found to have an EGFR positive lung cancer, which is not necessarily a shock to the clinicians, but when you start thinking about the number of patients that do have this. A couple of years ago, in 2023, we've had our first chance at a look back of nearly 1 million people that have been screened and placed into the ACR, or the American College of Radiology's cancer registry. The biggest thing that we know is a problem is adherence rates. And so when you compare that to our stage one, also comparing the stage one diagnosis rate. So when you look at that in comparison to national average, so people that are enrolled in a screening program almost double their chances of having an early stage diagnosis because the average, for example, in the state of North Carolina is about 26% have an early stage diagnosis. And so if we can screen patients, obviously we can catch that earlier. And data points that a lot of folks don't necessarily know. It's hard to look at all of the studies to get exact numbers, but when you think of something called the number needed to treat statistically, in a study that's considered one over the absolute risk reduction, or number needed to save a life when you look at colonoscopies, mammograms, and low dose CTs. Colonoscopies take somewhere around 1,000 to save one person's life for finding a malignancy in the colon that would potentially take someone's life. Mammogram, roughly around 900 or 860, you see there. And low dose CT is only 320 is needed for that. I'm pretty excited to say that North Carolina just hit double digits in the release from the American Lung Association for lung cancer screening. I wholeheartedly believe that the Lung Cancer Initiative is responsible for helping push North Carolina into double digits for the screening of eligible populations. And that comes with just community engagement and people understanding more so that lung cancer screening saves lives. If you can catch it early, these are all lung cancers, these are all stage one lung cancers, but if you can catch it early, 5 year survival is much improved for smaller the lesions. When you think about lung cancer across the board, roughly 66% or so are advanced stage malignancies at diagnosis. So I always tell people all the time, it's not necessarily us doing a better job with the patients that we are finding early stage, but what can we do for that other population by internally shifting them to an early stage malignancy? This is looking at the incidence rates for lung cancer in our state. Um, this is important to me because the practice area and the patients that I provide care for are all in the counties that you see there in yellow. So when you look at U.S. national average rates for the development of lung cancer, and you look at the North Carolina average incidence rate for lung cancer, these we have a lot of counties in North Carolina that are well above national average, which is not surprising considering smoking rates in the United States somewhere around 12%. about 14.5% for our state. And then the area in which I practice is about 26% smoking rates. Lung Cancer Initiative is doing a great job with the Screening Saves program and working to engage all of the local health systems and communities to ensure that we are getting people there to get screened who are eligible. And that's why we are able to push into those double digits as we have over the past couple of years. So I'm going to stop talking now and pass the baton because I could probably sit for the next hour and do so. But thank you guys for having me this evening.
So I'm going to talk about updates in early stage lung cancer from a thoracic surgeon's perspective. Um, it's kind of fun because there are things that we can talk about now in early stage lung cancer where this is part of the reason why I went into thoracic surgery was specifically to kind of occupy this niche because originally all that you could do is do surgery for most early stage lung cancers unless people were not an operative candidate. The world has changed, and I'm excited about that because I think multimodality treatment is the future of cancer therapy, but particularly in lung cancer. And it's going to transform how people live with lung cancer, how we view it, and most importantly, how we impact survival. So forgive the fact that I like to go over this because we assume that everybody understands what early stage lung cancer is, but early stage means stage one or stage two. According to the most recent AJCC guidelines, all T1 lesions without nodal or metastatic involvement would be considered stage one. T1 lesions with N1 nodal involvement only are stage two. You could have a T2 lesion without N1 nodal involvement, or T3 lesions without nodal involvement. Those all would fall under the broader classification of stage two. Now, of course, we can't just leave things alone. We've got to make things complicated. So here's a really colorful rainbow of what that actually means. So we have T1, A, B, and C for sizes for the initial tumor size, and then what that means in terms of nodal involvement across the top. Basically, the world is getting more complicated. And of course, now that we finally got comfortable with this particular TNM staging, they're going to change it again, probably in the next year. This is in words for those of us who are analog people and color people. But what's interesting is that when I started looking at lung cancer, as a trainee, we didn't have all these designations that are so minute in terms of size. But what's happened with the World Lung Cancer Society and the IASLC is that they've actually looked at the data and how people survive. And over time, they refine what staging means based on how do people do, trying to pull out who really is at risk, who actually does well. And based on tumor, it used to be that if you had any sort of metastatic disease, stage four, you were going to have a very poor prognosis. We found that some people with isolated metastatic disease and isolated brain met, oligometastatic disease is totally different beast than someone who has miliary pleural involvement. So let's talk about early stage cancer. So there's two ways that we originally would approach this. And I like to call it either local therapy or ablative therapy. So either you're a surgeon and you're cutting it out, or you're a radiation therapist and you're zapping it. Surgical resection, whether it's a lobectomy or an anatomic sublobar resection, has been the gold standard for probably the last 40 years. We have now transitioned from an open resection to minimally invasive, becoming the rule rather than the exception in the last 20 years. And it allows for mediastinal lymph node sampling. And that's really what separates it from radiation therapy and other modalities. Having that mediastinal lymph node sampling, not just FNA, really gives you a very precise view of true stage and therefore true prognosis and treatment implications. Radiation therapy, however, has equivalent outcomes in the short term, anywhere between 3 to 5 years, equivalent to lobectomy head-to-head for patients who otherwise could not undergo resection, but for the same size, same morphology, and the same histology of their tumors can be treated equivalently, minimal morbidity, and excellent local control. With the advances that have happened with the delivery of radiation. It has allowed even greater precision through the physics of how the therapies are administered that can give us even more robust and durable local control with less frequent recurrence. But once again, you're going to hear this over and over again. Getting something early is really the key to having a great outcome, as opposed to the modality that we're using. So let's talk about what's new. So what's new is actually that finally we surgeons got up off our tuchuses and decided to do a randomized controlled study looking at lobectomy versus sublobar resection for, wow, this is really hard to see. Sorry, guys. For peripheral stage 1 tumors that are less than 2 centimeters. They did a 7-year follow-up in that study, and it actually confirmed non-inferiority of lobectomy versus sublobar resection in terms of disease-free survival, overall survival, local or distant recurrence. And all that that means is that we had been trained from our baby surgeonhood to believe that you get either go big or go home. You do a lobectomy, that's your only chance for cure. And we found that actually a very meticulous, still anatomic, but sublobar resection can be equivalent to a lobectomy for these smaller tumors. There's only a 2-point difference in FEV1 at 6 months postoperatively between groups, and it somewhat favored the sublobar group overall. This has created a lot of waves in the world of thoracic surgery because it's changing the way that we look at how we approach resection in the anatomy of lung cancer. So our Japanese colleagues have done a similar study. It was a 5-year randomized controlled study of lobectomy versus segmentectomy in stage 1A tumors, once again, less than 2 centimeters, similar median follow-up. They found a statistically significant non-inferiority and superiority in their hands of segmentectomy over lobectomy. There was no statistically significant difference in FEV1 at 1 year, and the 5-year disease-free survival was equivalent. Local recurrence was slightly higher in segmentectomy over lobectomy, and it was statistically significant with a p-value of 0.0018. But overall, this has really kind of rocked our world, and finding that in the appropriate patients, we can do lung-sparing, minimally invasive resections and give people an equivalent oncologic outcome. So as if that wasn't enough, wait for it, we've got another slide. So now the world of neoadjuvant therapy has left kind of advanced stage disease, which is, we initially found that people were getting systemic therapy for unresectable disease, and then stepping back to, hey, maybe we can downstage people from, an advanced stage disease to a resectable disease. And then we've actually moved the needle even further to the left to even earlier stage cancers, and finding that for certain subtypes and certain sizes that still would meet criteria for early stage disease, stage 1, but usually stage 2 disease. There's a meta-analysis that recently came out in JAMA Networks that looked at several phase 2 and 3 randomized controlled trials with looking at patients who were known to be resectable with early stage lung cancer to see whether or not there was any treatment benefit of adding chemotherapy with or without immune checkpoint inhibitors. We actually found some very important pieces of data. We found improved 2-year event-free survival, as well as improved path CR. And that improvement was actually independent of the PD-L1 status, platinum compound chemotherapy, and number of neoadjuvant ICI chemotherapy cycles, or the addition of adjuvant immune checkpoint inhibitors. What this means is that giving some sort of systemic therapy, whether it's chemoimmune or chemotherapy prior to resection, radically changes the impact of a surgical resection, even in early stage tumors. And this is really kind of wild, and that impact remains durable, independent of adjuvant therapy. So this is really kind of, for me, one of the things that has really radically changed the way I look at my patients, the conversations that I have with my patients, and also discussing with people that it's not surgery or chemotherapy. It's what makes sense for the biology of your tumor and what is going to get us the cure that we're looking for. The wonderful thing to pass on to our patients is that cure is so much closer in our reach and expands across many more patients than it did before. It used to be only about 29% of patients, even with early stage cancer, were had a 5-year survival 20 years ago. That's radically changed, as you can see from Dr. Eichard's slides. That if you can get somebody at a stage 1, they can have, upwards of 50 to 60% 5-year survival. When we add neoadjuvant therapy on that, that blows the socks off those statistics. And that's meaningful. And it really needs to be part of our conversations with our patients to really dismantle a lot of the folklore around cancer therapy, systemic therapy, what it means, what it does in the biology of tumors, whether aversion to biopsy or surgery or aversion to chemotherapeutics, and not really understanding what the world and the terrain looks like now as opposed to what chemotherapeutics looked like in the 70s and 80s. So as a summary, as staging becomes more precise, ablative therapies remain integral to lung cancer treatment. Surgery has continued to evolve to embrace lung preservation without impacting oncologic outcome or survival. And once again, the big take-home message is that the new wave, the new vanguard for us is multimodality therapy, excuse me, along with early molecular testing. And this will continue to radically change both our surgical approach and our patients' outcomes.
Well, welcome everybody, and thanks to everyone for participating. I'm Neil Reddy. I'm a medical oncologist at Duke Medical Center. One of my areas of clinical research interest has been small cell lung cancer, so I'm going to talk about some recent updates and future approaches. So, standard of care for small cell lung cancer has been evolving significantly over the last 10 years. Now, for extensive stage small cell lung cancer, standard of care would be chemotherapy plus one of the approved anti-PD-L1 antibodies, such as atezolizumab or durvalumab. For limited stage small cell lung cancer, where the cancer can be potentially cured, therapy would be concurrent chemotherapy and radiation, followed by maintenance durvalumab. And in the 5% or so of really early stage small cell lung cancers, surgery followed by chemotherapy, and maybe in the future chemotherapy, immune therapy, can have a significant cure rate. So new in small cell lung cancer are a new chemotherapy, antibodies against specific small cell lung cancer molecules, antibody drug conjugates, bispecific antibodies, and CAR T cells. So for small cell lung cancer, at least at this point, we haven't had the typical actionable molecular alterations the way we've had in non-small cell lung cancer. So we don't have cancers with the equivalent of an EGFR mutation or an ARC or an ALK translocation that allow us to treat the cancer with some well-tolerated oral therapy. But there are some unique things about small cell lung cancer that are really going to let us focus specific treatment on the cancer. So when cells that are lining the lungs are exposed to carcinogens, and most people with small cell lung cancer have a significant smoking history, these cells evolve and develop a neuroendocrine phenotype where the cells have many similar characteristics to neuroendocrine cells. And what that ends up with is that the cells will have proteins on their surface that are not on the surface of 99% of the cells in our body. So this is just a cartoon to simplify and illustrate that. So if this is a small cell lung cancer cell, in the middle we have a nucleus with the DNA, and then in the darker blue is the cytoplasm where a lot of the cellular machinery is. But then there are often proteins that span between the inside of the cell to the outside of the cell. And these cells and these molecules that stick out from the cell are available to be identified by the immune system. So some of those surface molecules that are important in small cell lung cancer are DLL3, B7H3, TROP2, SEZ6, fucosyl GM1, and there are a number of others. Antibodies are these amazing immune proteins that have a heavy chain, but then on the other end have these variable antigen binding sites that are able to identify very specifically the three-dimensional structure of parts of proteins. This in normal physiology, this allows the immune system to identify bacteria, virus-infected cells, parasites, and other foreign invaders, but also sometimes to recognize cancer cells if the cancer cell has become very abnormal, is in expressing abnormal proteins. But what we now know is that many of the small cell lung cancer cells just express normal proteins at high levels, and we can now leverage this to treat the cancer. So one way to treat the cancer is to make a monoclonal antibody against a cellular target that sits on the surface of the cell, and then give a whole bunch of the antibody, and the antibody gloms on to the cancer cell and makes it a target for the immune system. Antifucosyl ganglioside 1 is a antibody developed by Bristol Myers Squibb. It now has a name, adagrotag, and that has had a positive phase 2 trial with chemotherapy and immune therapy, and is now in a large phase 3 trial studying chemotherapy and immune therapy with or without the antifucosyl GM1 antibody. Antibody drug conjugates are hot in small cell lung cancer, just like a whole bunch of other types of cancer. So some of those proteins I reviewed earlier, like DLL3, TROP2, B7H3, SEZ6, all have antibody drug conjugates that are in development. So an antibody drug conjugate would be a monoclonal antibody that has been developed against the target of interest. In this case, like DLL3 or TROP2 or B7H3. And on the constant region of the antibody, you tag it with highly toxic chemotherapy molecules. In this cartoon right here, you can see them as yellow stars. When the antibody drug conjugate latches on to its protein target on the cancer cell, the antibody drug conjugate gets pulled into the cancer cell, and the chemotherapy units dissociate and poison the cancer cell. So it's sort of a targeted chemotherapy. The way I explained it to my patients is it's like rather than some sort of random bomb, it's a smart bomb. Bispecific antibodies are now in the clinic for small cell lung cancer, and the lead target has been DLL3. Tarlatamab and other agents are being studied in clinical trials. And when I say bispecific antibody, that means that the antibody recognizes two different targets. And often the bispecific antibody may latch on to a extracellular protein like DLL3 that's on the surface of the cancer cell that you can see on the left-hand side of this slide, down below, and then also onto a protein on an immune cell. to a T cell. If you look in the middle, that shows that the T cell and the cancer cell are pulled up right next to each other by this bispecific antibody. And that enhances the opportunity for the T cell to attack the cancer cell because it's bringing the T cells right up to the cancer cell and activating it, shown on the right-hand side of this panel. There are even CAR T cells now. So T cells are the cells of the immune system most responsible for attacking cancer cells. But they're very complex. They're easily turned off. And if they're turned on too much, they can cause problems. So there are now designer T cells developed that are able to activate the cell once it hits the target very rapidly without the need for multiple positive feedback loops, but also detonate the T cell when it's been in the body too long so that it doesn't cause side effects. This is these CAR T cells in small cell lung cancer are in early clinical trials, but the results have been quite promising. So ASCO 2025, I want to finish on a couple of potentially practice-changing trials. So M-Forte was studying one of the new chemotherapies, a drug called lurbinectedin, which is a cancer drug that was identified from an invertebrate sea animal. And in a large randomized phase 3 trial, patients received standard chemotherapy and immune therapy as their induction phase. And if they had cancer control at the end of the chemotherapy and immune therapy, they were randomized to either get the atezolizumab alone, which would be standard of care, or atezolizumab plus the lurbinectedin. There were increased side effects from the addition of chemotherapy, but not what I would deem to be excessive. But there was a clinically meaningful improvement in overall survival that I would deem a step forward in treatment. With tarlatamab, one of the lead DLL3 bispecific antibodies, a randomized phase 3 trial was done in the second-line setting for patients who progressed after receiving chemotherapy and immune therapy. And patients were randomized to either get tarlatamab, the bispecific antibody, or standard of care choice of chemotherapy. There were the typical side effects of tarlatamab that can be significant. And tarlatamab, at least at this point, requires hospitalization for the first and sometimes the second dose. But there was a significant improvement in overall survival favoring tarlatamab, meaning that tarlatamab should get final approval in the use of small cell lung cancer. So for updates on small cell lung cancer, I think that small cell lung cancer cell surface often has novel proteins. Some of them are DLL3, B7H3, TROP2, SEZ6, fucosyl GM1, and several others. I apologize to anyone who has drugs in development against the others. These targets are very accessible to antibody-based therapy. Both antibodies, antibody-drug conjugates, bispecific antibodies, and CAR T cells can be used against these specific cancer-specific proteins. And as we just saw, novel chemotherapy is still an important potential new option in different cancers. For ASCO 2025, maintenance lurbinectedin was a positive trial for overall survival, and second-line tarlatamab improved overall survival compared to standard of care. And I think that compared to decades ago, when we might go years without any real progress in small cell lung cancer, I think we're seeing frequent positive phase 3 trials that advance the standard of care, and phase 1 and phase 2 trials rapidly identifying really promising new approaches that I think will move the needle for both efficacy and tolerability in the future. So compared to 20 years ago, where things were somewhat dismal in small cell lung cancer, I think things are really promising, and I think there's a strategy to go forward and really improve outcomes. So thank you very much for your attention.
Thank y'all so much. I'm going to give the updates in more advanced non-small cell lung cancer. There we go. So these are facts that we've seen before, but if we're talking about updates, we want to think about every time the ACS releases the information on cancer statistics. Lung cancer is still the second most common cause of cancer, both men and women. I've actually put some of the statistics for North Carolina as estimated for the year of 2025. And lung cancer remains the most common cause of cancer-related death in both men and women. And as we've really pushed that needle for people to recognize that the risk factor for lung cancer is having lungs, and there are many people who we have yet to identify a potential risk factor for that diagnosis, particularly in our never smokers, we still need to maintain that diligence in screening for high risk people, smoking cessation, because it is still that 85% of our lung cancer related deaths in 2025 will be related to cigarette smoking. And so you see here with this 5-year relative survival rate for cancers that lung cancer is circled here, that the for distant disease, that 5-year relative survival rate is still staggeringly low. And certainly when we compare to other malignancies, and even more importantly, in our localized and regional diseases, that we are just barely getting above the 50% mark in our early stage disease for that 5-year overall survival. So certainly a need for improvement. And we're seeing that, right? So these are the trends, and the lung cancer is the red curve. And this is a most impressive data set demonstrating that cancer mortality in both men and women related to lung cancer is decreasing, and that is because of these advances, not just in immunotherapy, but also in targeted therapies, as well as early detection using multimodality therapy. This is what everybody's been discussing this evening. So we are making headway. And this is an older slide of mine from 2019. And I was so proud of this slide showing the targeted therapies that were FDA approved. Among these 4 actionable mutations in EGFR, CROS1, and BRAF. And here it is today. So this is a busy slide because we are making progress. And the updates here, you'll see in those yellow stars, regimens that were FDA approved in 2024, and in the red stars, FDA regimens that were approved in 2025, and we are just starting our 4th quarter of this year. So we've been so pleased with the advancements even beyond osimertinib, with trying to understand mechanisms of resistance or higher risk disease, and how do we combine osimertinib with chemotherapy, or use lazertinib, another 3rd generation EGFR tyrosine kinase inhibitor, with amivantamab, bispecific EGFR and MET drug, and demonstrating that when compared with osimertinib alone, these newer regimens and novel combinations are improving survival. And we are seeing that not just in across the board, but really as we divide these subsets into understanding and further personalizing, who is the patient, what is their disease burden, what is the tumor situation, whether there's a complex mutational burden, co-mutations with TP53, baseline circulating tumor cells, liver metastasis, and importantly, the brain metastasis component, where maybe we've been skeptical about chemotherapy's role in the blood-brain barrier penetration, but we're seeing these improvements in the combination approach. But importantly, what do we do next, right? Well, we know in all of our patients that a therapy eventually no longer provides the benefit that we set as our goals. And so we are making advancements in what would be a next line therapy. And for that, I just kind of want to focus on a really novel trial design. So with this Tropion lung study, really the patient inclusion criteria were all patients with various actionable mutations that were seeking a next line therapy and evaluating the efficacy and safety of Dato-DXd in this space. And what we see is that in those patients with MET exon 14 skipping, ROS1, RET, and even ALK, that Dato-DXd as a next line therapy did not demonstrate a reasonable and appropriate response rate. However, in this EGFR space, there was a significant response of 43% in 78 patients with EGFR mutations that had progressed on their prior therapies. And what's really key here is that the heterogeneity among these EGFR mutations, there could have been resistant mutations, the T790M, there were some exon 20 insertions included. There was even C724, which is in the exon 18 space. And so really not in that typical binding site for your third generation EGFR TKI, but to see median PFS and then look at this median OS of 18.3 months. So Dato-DXd received that FDA approval June 23rd after a TKI, after chemotherapy. And so I mentioned the exon 20 insertion space and how limited that was previously. Tremendous advancements with the utilization of amivantamab plus chemotherapy now in the first line, whereas initially it was solo in the second line space. And we have recent approval of sunvozertinib, which is a EGFR exon 20 insertion tyrosine kinase inhibitor. This is an oral agent that was approved July 2nd of 2025 after platinum-based chemotherapy. This is based on the Wukong data. And I'm not going to present the Wukong data. I'm going to present zipalertinib data. This is a similar agent. This is also an EGFR exon 20 insertion. Tyrosine kinase inhibitor is an oral agent. Zipalertinib is not yet FDA approved, but I want to highlight the resilience study that showed a heavily pretreated patient population, prior chemotherapy in the majority of these patients, prior immunotherapy in the majority of these patients. And in those previously treated, 83% had received amivantamab, and actually 40% had received mobocertinib, no longer an agent that has approval. So in this heavily pretreated space, we can see on this waterfall plot the benefit of zipalertinib, both in the patient population of platinum-based chemotherapy without a prior exon 20 insertion targeted therapy, as well as those that had previously received amivantamab. And you can see on the curve here, looking at overall survival, even in those patients who had previously received amivantamab, representing 51 of them, that 12-month overall survival rate of nearly 60%. Shifting into the ROS1 space, this is a tumor that is an uncommon, representing around the 1 to 2% of the lung cancers that we identify, and we've made tremendous strides in the therapies specific to the ROS1 tumors. beyond entrectinib, I mean, actually beyond crizotinib, beyond entrectinib, most recently repotrectinib, and our most current FDA approval was with taletrectinib, receiving that date on 6/11 of 2025. Then what's impressive about taletrectinib is, again, continuing to increase that response rate, improve the duration of response, then the PFS. This drug is highly penetrant of the CNS, tends to be more tolerable than the other agents previously FDA approved, with slightly less inhibition on that NTRK component, and so reducing some of that edema, but still seeing some of the stress fractures and other things that we've associated with that. There is still another ROS1 inhibitor that is yet to be FDA approved on the horizon, the NVL-520, also highly effective as taletrectinib against your mechanism of resistance, that G2032R finding, but specifically not hitting NTRK, so reduced toxicity there. Shifting gears to the HER2 space, having the Enhertu as an agent that's being utilized due to its efficacy, slightly lower dose to reduce interstitial lung disease as a toxicity in comparison to the dosing utilized in the breast cancer space. As a subsequent line therapy, so chemotherapy still preferred and recommended as that first line, within HER2 as a subsequent line. However, we've got recent FDA approval as of August 8th of this year for zongertinib, which is actually an oral HER2 inhibitor. It's a tyrosine kinase inhibitor. It is sparing that EGFR binding site, and so limiting some of that additional rash and diarrhea side effect that we've often seen with our EGFR TKIs. And when we look at the entire data set that led to the zongertinib approval, beyond the efficacy, really honing in on that toxicity profiles with no drug-related deaths. And in this particular data set, no cases of interstitial lung disease or cardiotoxicity noted. And you can see here that when we look at the data in the entire patient population, as well as those who had previously received a HER2-directed ADC, which would be something like Enhertu, we are still seeing in that heavily pretreated population previous HER2-specific therapy response rates with zongertinib close to 50%, with disease control rate of 97%, and additional data that we anticipate to see in upcoming meetings such as World Lung and ESMO Conference, and that FDA approval just recently. So now moving into the MET space, which has been really a hard area to target, which has been frustrating because MET is overexpressed in 40 to 60% of the non-small cell lung cancer patient population. And Teliso-V was FDA approved in May of this year, based on data that demonstrated with that high c-MET expression, so 50% of the tumor cells with that strong staining, demonstrating response rates 35%, disease control rate of 60%, PFS in that 5-month range, but overall survival of well over a year, nearly 15 months, with 57% demonstrating 1-year survival. Now, this agent does have side effects with different laboratory abnormalities and peripheral neuropathy that require monitoring, but certainly a tremendous advancement in trying to target MET. So really what we see is that there's just been a tremendous, and there continues to be tremendous advancements in the advanced or metastatic setting. And really all that I focused on is that metastatic setting, within the actionable mutations. But it's important that there is no known mutations unless you've tested for it. All of these selective treatments ultimately kind of limit their ongoing response with a need to understand that mechanism of resistance, which could be on target, off target, or even a transformation in the tumor itself, specifically transforming to small cell or squamous cell. And in that situation, there's no known mechanism of resistance unless you test again. So, really, that overarching message is test up front, test at progression, and continue to assess an opportunity for a newer agent or one that's within the clinical trial space. So, with that, I will complete my presentation and shift it to our next speaker.
Hello, everybody. So today I will be briefly talking about toxicity management for immune checkpoint inhibitors. These are my disclosures. So we have many PD-1 and PD-L1 and CTLA-4 inhibitors approved for lung cancer. These are the immune checkpoints in the middle here. And the mechanisms of immune-related adverse events are kind of it's still being teased out. We don't fully know why all this happens, but there are some tumor-specific factors such as neoantigen host antigen homology, tissue-specific cross-reactivity, and host genetics. And there's some non-tumor factors such as viral, microbiome, cytokines. So a lot of research is ongoing in this field. In terms of the incidence and distribution of the immune-related adverse events, quite diverse. Start with encephalitis, but you can get rare things like uveitis. Commonly see pneumonitis, endocrine disorders, rash. But you can have very, very, very rare things as well. So, it's very, very hard to tease out when patients report their side effects and symptoms. So, always have to be suspecting a possible immune-related adverse events when patients report. In terms of metastatic non-small cell lung cancer, we find that endocrine disorders seem to be the most common. Then we have pneumonitis and then arthritis, colitis. Things like nephritis, pancreatitis seem to be lower on the incidence list, at least for our lung cancer patients. Lots of research ongoing from the preclinical setting, getting preclinical immune-related adverse event models, finding genetic biomarkers of this risk, looking at the microbiome, and then also looking at biomarkers, like can we predict who's going to have a toxicity and who's not? Can we do something to prevent that if they are? And then some prospective immune-related adverse event trials to try to figure out how we should ideally treat patients who have this. A lot of our patients get both chemo and immunotherapy, especially in the metastatic setting. So quite hard to tease out what is, when patients report a symptom, what is the cause of it. But there are some clues, such as something like uveitis, myocarditis, and pneumonitis, a lot more common with immune checkpoint inhibitors than with chemotherapy. The timing of IRAs in the acute setting, colitis, and maybe a rash seems to be quite early in the course. But then later on, we can get pneumonitis and something like nephritis would happen much, much later. If patients are on PD-1 as well as a CTLA-4, the toxicity grade can be much, much higher. You see in this middle graph here, and can be even earlier in the course. There was a study done in an ER looking at patients who reported the ER with these immune-related adverse events, and this graph is to show such wide timing. So reported symptoms as close as 1.5 days after receiving an immune checkpoint inhibitor, all the way to 180 weeks. Some of these immune-related adverse events can turn chronic. The ones that seem to be turn more chronic is our endocrine disorders, such as the thyroid issues, the adrenal insufficiency, and hypophysitis. But some of the other ones can also, the skin issues can also turn chronic as well. That can complicate the situation because unfortunately a lot of time we may need to if patients are stable and they're fine, but then sometimes the tumor can come back and then we need to re-challenge them with the immune checkpoint inhibitors, and having a chronic immune related adverse event can quite limit their treatment options. So, in terms of workup, we have very nice guidelines now. So, we have the CTCAE, which helps us grade these toxicities. And there were multiple societies that have released guidelines, so the NCCN, the Society for Immunotherapy of Cancer, and ESMO, that have released guidelines for how to manage this. But first, we want to start with getting a good medical history and doing good physical exam for our patients. And then start thinking about discussing with specialists, because as oncologists, we may not be savvy to some of the intricacies of all of, the side effects that can happen when an organ system is affected. So, discuss with specialists. We can consider some non-invasive imaging, CTs, MRIs. There's a whole plethora of blood work we can get depending on what the what we are suspecting is affected. And unfortunately, some patients will need some invasive procedures to get confirmation of the immune-related adverse event. Management, our mainstay of management is steroids. For grade one, with the exception of neurologic and cardiac toxicities, we can often continue the immune checkpoint inhibitor with very, very close monitoring. But if it's grade two or higher, we really want to stop the immune checkpoint inhibitors and start steroids. Can be, very high dose of steroids for things like myocarditis. If they have an endocrine disorder, you really want to start the appropriate hormone therapy for that endocrine disorder because steroids alone will be insufficient. And then if they don't respond in 48 to 72 hours, we have to consider additional immunosuppressants more than steroids. Things sometimes we forget is when people are on such high dose steroids, we have to consider some supportive measures like proton pump inhibitors for GI prophylaxis, prophylaxis against opportunistic infections, figuring out if patients have any predisposing diabetes, and screening for other infections. Very, very close monitoring, proactive weekly communications with patients while we are trying to taper off their steroids once their reaction calms down. There's lots and lots of other drugs being looked at and being used and being studied. A list on the right side over there. Tocilizumab is an IL-6 inhibitor that is used for multiple immune-related adverse events. We have infliximab and vedolizumab for colitis. We have tofacitinib for cardiac toxicities, myocarditis, as well as colitis. We have mycophenolate for liver toxicities, IVIG for immune-related adverse events of the skin, so dermatitis. And then we have multiple drugs being looked at for cardiac toxicities, such as abatacept, alemtuzumab, and ATG. So lots and lots of research going on. So, the future is not looking like just steroids anymore, which is important for our patients to have more specific therapies for this. Now, Dr. Reddy mentioned about the DLL3 bispecific T cell engager called tarlatamab. So us lung cancer doctors are also learning how to manage some of these other side effects that we were not used to, that our hematology colleagues were more savvy in managing. So one of them is cytokine release syndrome. So in this one, you kind of want to grade it and then manage it with appropriate supportive measures, as well as things like tocilizumab, steroids. Need to consider ICU support. The immune effector cell-associated neurotoxicity syndrome, called ICANS, is something that we also are learning now. We have to use the neurological scoring system, which we're getting better at. And then lots and lots of, help from our neurology colleagues to consider anti-epileptics, steroids, and other agents such as anakinra and plasmapheresis. So we're learning as we go along. There are some populations of patients that have been excluded from clinical trials that we do see in real life. And, some of them do need immune checkpoint inhibitors. And one special population is those that have paraneoplastic syndromes. So they have been excluded from clinical trials. So we are relying a little bit on some retrospective multi-institutional study looking at patients with either endocrine or neurological paraneoplastic syndromes. And what they found in this study was that the exacerbations of the paraneoplastic syndrome occurred in about 29% of patients quite quickly, about a month after starting the immune checkpoint inhibitors. So not everybody had an exacerbation. So certainly could be, should not be fully excluded. Should not be a full contraindication to giving immune checkpoint inhibitors in those that are paraneoplastic. Another population that we often see in our clinic is those that have pre-existing autoimmune diseases. We have to consider here the organ involved, the severity, and the need for immunosuppressive medications. In some retrospective cohorts that looked at multiple autoimmune diseases in patients, there was about a 25 to 50% risk of flare. So not everybody had a flare. Certain patients, depending on how controlled their autoimmune diseases, could be considered. We can consider concurrent disease modifying agents or low dose prednisone while we challenge them with immune checkpoint inhibitors. But if something is life threatening, like a neurological autoimmune disease, and those patients are probably, the immune checkpoint inhibitors are probably contraindicated in those patients. Now, the population is solid organ transplant that have been excluded from clinical trials. However, there have been small studies that show that it may be possible for renal transplant. In a small study, I mean, these studies have to be very, very small. Unfortunately, it's tough to do these large studies for transplant patients that included a few patients with lung cancer. The allograft rejection was in the order of 25.8%. So the left thing is the whole population. But if you look at the lung cancer specific population, the rejection was only about 9.1%. So, if a renal transplant patient didn't have another option, something to think about that maybe, if the immune checkpoint inhibitors would be significantly improve their survival for lung cancer, maybe should be considered. Rechallenging after immune-related adverse event is a hot topic as well. Several studies have been done, and a meta-analysis of 36 studies showed that the immune checkpoint inhibitor rechallenge was associated with actually a lower incidence of all grade and high grade immune-related adverse event compared to initial checkpoint inhibitor treatment. Could be also like the management, because people are more vigilant about patients who've already had an incident. So things to consider is it safe? Can you consider a concomitant immunosuppressive therapy, like not steroids? And then very, very, very close monitoring, like weekly evaluation, pretty much in some way for these patients, so you can stop it or treat appropriately with steroids or other immunosuppressive agents. One thing I tell my patients that's a silver lining when they're so disappointed after they have an immune-related adverse events is long-term disease control. So in a cohort of about 803 patients with metastatic non-small cell lung cancer, they looked at those that had the immune-related adverse events and those that did not, and actually found an improvement in survival. It could be, having an immune-related adverse event at least, could be almost prognostic that this survival could be better. Maybe needs to be a lot more studied, but something I tell my patients so that they have some kind of hope at the end of when they're disappointed with having to stop their checkpoint inhibitor. So overall, to end, we want to give patients things like wallet cards, especially, where I am in South Carolina, where our patients live like 3 or 4 hours from our center. They have to go to their closest ER, and, the physicians there, don't know, the patients can't tell them what drug they're on. So if they have a wallet card that tells them what their drug is, it might give a clue for the ER physician to start steroids, if needed. while they try to reach us. Educate all our colleagues as well as patients, more importantly, our patients and their caregivers, identify early signs of toxicity, collaborate with our specialists. We are all learning to be, wear multi hats right now because we have to think very organ specific. We have to act very fast. We may not have time for all the results before we actually start steroids or what the suppressive therapy. And then we need to have very, very close monitoring and adjust treatment as needed. Thanks so much for your attention.
All right. Very good. Thank you so much. Wow, that's an incredible set of talks we just experienced. We started off with lung cancer screening and learned about how early detection can really change lives. We moved into thoracic surgery, early stage disease. It reminds us that timing can truly be curative. And then we explored the latest updates in small cell lung cancer, where we're making progress in an area that we used to say this was one of our toughest arenas. Um, we wrapped it up with advances in non-small cell lung cancer, where innovation in targeted therapies really transforming outcomes, and then learned a great deal here just recently with immune-related adverse events and the promise of treatment for those toxicities. So, taken together, let's look at lung cancer care from prevention to screening to surgery. Um, it really highlights how medicine today is about teamwork and integration, never losing sight of the patient at the center. And I think that the Lung Cancer Initiative has done such a wonderful job with events like this to really bring the patient back in center stage and in really informing us of how far we've really come. So now this is where it gets exciting. We want to hear from you. I put in my message in the chat to try to get some excitement over this. Please ask tough questions. The speakers love them. They're all about answering hard questions. So I'd love to open the floor. If you're shy, please put it in the chat. I don't think we can raise our hands on this one, on this Teams, or Zoom. If you can, but or just shout it out. But I'm going to get things started with a question, and I ask it every year, which is, even though we see this slow incremental uptake in lung cancer screening, Dr. Eichard, what are we waiting for? And what are the barriers that are getting us to where we need to be?
You know, personally, I think there is no one clinician, no one specialty, no one technology that is going to help solve the lung cancer crisis. This is our number one cancer killer, and this is a community effort. I think that lung cancer from a early on start, has a stigma that is associated with its disease that other cancers may not carry due to tobacco abuse history and those kind of things. So we, I think that we really have to work to change that mentality around that, as well as just making sure that people understand that it isn't a death sentence at the time of diagnosis. And as we have continued to gain traction, and when you think about it in general, you look at disparities even in funding for research in this space. When you compare it to others, I'm actually working on a separate talk, but to look at some different. I don't just know these numbers off the top of my head. I've just been recently looking at them, but 20 roughly, the entire U.S. healthcare cost for lung cancer management is around 20 billion a year, 23 billion. And to get a new drug to market for a cancer patient in the United States costs 1.8 to 1.9 billion to get it to market. And the issue is that we're spending a whole lot of money, in my opinion, in the wrong place. And we need to be spending that money knocking on doors and telling people that we need counseled on smoking cessation and other kind of things that actually help prevent the disease upstream versus downstream. So it's a long conversation that's very convoluted, but we got to start somewhere. And I think it's the Lung Cancer Initiative is a group of people that I wholeheartedly believe are working to try to change that across the state.
Yeah, thank you for that answer. Yeah, totally agree. Any other questions? There's a good one here. How about this one? This is looks like for you, Dr. Oliver. Um, Multidisciplinary care. It's important now, especially when we're talking about neoadjuvant therapies and transitions over to surgical intervention. And the idea is great, but in practice, many patients still don't really get it. It's still fragmented. The system, especially in rural communities. So are we just paying lip service to collaboration, or is this really going to happen at some point?
So I actually think it happens more than people realize. I think that the perception that somehow people are going to come into some big ivory tower and they are going to be surrounded by a cloud of doctors that are going to hover over them and make them well is not what actually happens. It's a lot of what happens in many local communities where you have each community will have its own quarterback. And the great thing about lung cancer is there are lots of points of entry. So if your quarterback ends up being your pulmonologist in a smaller community, you may actually be carrying the football further along than you would perhaps at a larger multidisciplinary center. Whereas sometimes I'll get a patient who's sent to me from the ER. I'm a thoracic surgeon. They may not even need an operation, but that doesn't mean that they get bounced out of my queue because I may be the only entry point to get them to the right person. So I really think we have to change the way we see multidisciplinary care. It's not, does each patient get touched by 5 doctors? Is, do the right people get to the right patients in the right order for them to get the right treatment? And we really have to make a shift from a monolithic view at cancer, because a lot of our conversations that all of us, no matter what our discipline is in lung cancer, the conversation that many of us are having with our patients is to move them from a monolithic view of I have the C word and you're going to give me poison, or you're going to zap me with radiation, or you're going to cut me to pieces, and you're going to put air on my cancer, and you're going to create all these spores that are going to fly everywhere, and I'm going to be ate up with the cancer. And we have to move that conversation to something that's much more informed, just like you would say for an individual. And the conversation that I have as a surgeon is, hey, it used to be all you got was aspirin, and that was it. That's all we had. Now it's like going down the soda aisle at Food Lion. It's not just Coke or Pepsi or 7-Up. There's 60 different kinds of Pepsi, much less Tab or whatever else you want to drink. And so I think that people don't understand that chemotherapy isn't one drug. It doesn't have one side effect. You're not going to look like a kid from St. Jude's, and that there's a powerful effect of allowing people to understand that, just because you'll get a chemo pill doesn't mean that you're going to be okay. There are many infusions that are not toxic. And I may be the person that has to initiate that conversation, even though unlike my, gyn-onc colleagues, I'm not giving any chemo. But I have to be the person who's going to rally and say, you need to meet with this medical oncologist. This person has the answers to the questions that you need. And sometimes we have to be our colleagues' wing person in order to get the patient in the door, to have the right mindset, in order to be open, to have the conversation so that they can make an informed decision about what makes sense for their care. And when people understand that it is tailored medicine, but that tailoring isn't because you fit into an algorithm purely based on NCCN guidelines, but that there is actually nuance and art to us having conversations with each other like tonight, but also that trickles back to our patients, and that people are seen as individuals, and that the potency with treatment comes with an understanding of a conversation. And that's one thing that I think LCI does very well, of giving voice to individual stories, and also giving community, where people tend to be pretty isolated around lung cancer and lung cancer treatment. They get overwhelmed and they believe that it's a death sentence. And they weren't wrong. But just like the lag time between, I can't even remember. Oh my God, now I'm showing my age. I can't remember. I'm seeing his face. He looks like a little bit the old Surgeon General from the 80s who started the whole lung cancer, the whole smoking cessation program. And it just radically changed what we see in terms of lung cancer. But we're seeing a 20-year delay. The same thing is that we're seeing a 10 to 11% decrease in lung cancer deaths over the last 5 years because of immune checkpoint inhibitors specifically. That's not an insignificant change. We're still not where we need to be. We're still the #1 cancer killer. But if I can't get people to consider that as an option, to understand that it's an option, not just to not die, but to live well, then I'm taking away survival that's right on the table for them. It's not experimental. So, when we think about multidisciplinary care, we have to be the hype people for our colleagues, even if they don't sit at the table or they don't have a place in our clinic, because it's going to be that lifeline. The other thing is that it goes both ways. I can do a biopsy for a patient. They can end up with the radiation team with chemotherapy, and they're not going to be an upfront surgical candidate. But I say to the patient, I am part of your team. And should your medical oncologist or radiation oncologist decide that I need to be part of your care again, I'm right here ready to jump in the game at any point. That's what we have to communicate to our patients. So I do think it happens more than people realize. I just think the format is different than what people are expecting.
Yeah, so true. Um, we're talking about decades of waiting. Dr. Reddy, progress in small cell lung cancer, painfully slow. This is the biggest year we had. A lot of changes, though. A lot of good research coming out. Do we need to rethink how our entire research approach is set up based on what you're seeing in the different research projects that are being rolled out?
Um, yeah, good question. I I don't know that we need to change our research structure, but I think that just the number of really promising new therapies um, is 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 really impressive, and I think that we're really understanding in other cancers like hematologic malignancies and whatnot, how to develop CAR T cells, bispecific antibodies, and such. And I think that this substantial number of cancer-specific molecules that are really expressed in small cell and not others. For instance, for almost all the ones I listed, like DLL3, SEZ6, B7H3, antifucosyl GM1, those are all present on about 70 to 80% of small cell lung cancer cells. So this isn't a rare target. Most of them have it. And for all of those targets I just talked about, very few normal cells express those, even nerve cells. So, the potential for a really good therapeutic index is there. And, we didn't have time to talk about, there are like 4 or 5 different molecular subtypes of small cell that we really haven't known how to target them. But I think what we are learning is that the different molecular subtypes are more or less likely to express the different targets like DLL3, SEZ6, B7H3. So it could be over time that we'll have directed targets, the cancer will progress, we'll analyze the cancer and realize that it's changed its subtype and it's changed its molecular, its cell surface expression pattern, and then we'll be able to go in with one of the other new targeted therapies that hits the protein that's being expressed on the cancer now. So in the same way that we do as Dr. Millen was talking about, if you don't test, you don't know. I think that we'll end up doing different types of serial testing in different cancers that will not just look at mutations or translocations, but will actually look at expressions of proteins on cell surfaces. So I do think that my level of optimism for having new and effective therapies is higher than it's ever been in small cell lung cancer.
Excellent. I'm going to turn this over. I think I'm at time. I'm going to turn it back to you, Paige.
Thank you so much, Dr. Ruiz. And thank you again to our panelists and for the great questions. That was a great peer exchange. And again, appreciate you all taking the time to participate and to share this important information with all of our attendees.